Okay, so we're here recording our review for Health Psych Exam 2 for Unit 2. So and we have more people coming in. So why don't I start with Isia? I'm pronouncing that incorrectly, but you were
Asia.
here.
Hi.
Say it again, sorry.
Asia, like the
Asia,
continent.
okay. It's for someone with such a difficult name, myself, I have a hard time also pronouncing other people's names.
No, it's okay, me too.
All right, so Asia, why don't you go ahead and start? And what we'll do is if I've found that the most beneficial is Asia's going to discuss or ask a question or something she has a difficult time with. Before I step in, I want to see if or give an opportunity for one of the other students in the class who might know the answer. One, it's just going to, it's a way to learn more information. I know that I learn very well by teaching. And so I will give the students opportunity to answer one another's questions. And then if you guys can't get to it, then I will do it. So why don't you go ahead, Asia, and we'll get started.
So I actually personally don't have any like questions right off the top of my head. I just wanted to join to like get the study going, I guess. So if anybody has like a question or a topic to start with, then I like feel free to take the floor, please, because I don't really have like anything personally. I just wanted to like to get in the motion of studying for the exam and everything.
Hey, that's a great reason to be here. Peer support and peer study groups have gotten me through a lot of difficult exams. So does anyone, you guys don't have to raise your hand, just speak out. It's a small group. Does anyone have a specific question or topic they don't understand, or a specific question about the exam that they would like to offer?
Well, I second what Asia said. This is my first time doing the question and answer thing with you. The reason why I joined is because on the first exam, I didn't do quite well. It's probably because I didn't have a pinpoint on what we're going to be tested on. So that's why I asked her during class, like, was it going to be a PowerPoint or a review of what's going on, so we know what to study, what to read? Because again, I have other classes and this is a lot of material that we went over with her. It's a lot of chapters. So if you give me an example, like, okay, study hypertension or diabetes, how it works or something like that, like, just like pinpoint a little bit so we'll know. I mean, that's what I'm speaking for myself. I mean, that's how I feel, because again, it's a lot of information. So I just want to be guided through it a little bit because I didn't do good on the first test.
Okay. Is that pretty much what everyone who's here feels? No, there is not a study guide. So listen, I have taken classes. So I've been in your shoes with Dr. Mers. And then I've also TA'd this class for 2 years. So what I can do, because it looks like, all right, let me go through it real quick. Does anyone have any specific questions? Crickets. All right. Then let's go through. I'm going to go ahead and share my screen. All right. And we are going to go through the units for this chapter, okay? Or the chapters for this unit. Let me go ahead and share screen. All right, so you guys can all see this, right? Yes. Yes, the recording will be available later. Okay, so I don't know if you guys know how to utilize this. So let's say you've all signed in, right? And you'll see health psychology right here. Mine might look a little bit different than yours. But when you go down here, let's go and let's see. So, right, you have the general information on the exams. And then where does she have her, and then here, notes and stuff. Have any of you, just speak up because I can't see the video. Have any of you been here in the notes and stuff part?
Yes.
Okay. So you know that unit 2 is what you're having your exam on, right? And this contains everything, everything that's in the exam. So this is what is on the exam. So what I have done and what I did when I was her student is I would open them all out like this. So I did this ahead of time for you guys. And so what I do here, and if you want to, so I have an hour with you guys, and I would like to use that however you think, you know, is most beneficial for you. And so if you want to, right now, I can go through these. And if you have questions or don't understand the topic, then you can stop and we can discuss it.
That would be perfect for me.
Okay. All right. Fantastic. I can't see your faces anymore, not that anyone had them up anyhow, so all I can do is just verbally hear you. Okay. So we're going to start with longevity. Do you guys remember the discussion she had about Loma Linda?
Yes.
Right. And I grew up in the IE, so you know, it's next to some places where people have a lot smaller life expectancy, right? So when you're looking at quality of life, right, there's it's beyond a direct measure of population health, right? It includes that. It includes causes of death and life expectancy, right? So it's a multi-component. Quality of life is a multi-component factor. And so that's where you get into those components. So longevity is the length of life. Life expectancy in the US is increasing. Now that with COVID, I'm sure those numbers will move around a little bit. Now, in fact, that would be a very, very interesting research paper. I do COVID research, so that would be super interesting. So what this unit got into as well was chronic illness. So approximately 1 in 2 Americans, so over 50% of US population experiences some kind of chronic pain. Comorbidities are common. Who can explain to me what comorbidities are?
It's when you have more than one chronic issue, I believe.
Right. Perfect. So let's say for me, I have arthritis, right? Which is not a comorbid condition, but I also have psoriasis, right? And that and psoriatic arthritis then become comorbid conditions, right? But they're all linked together as chronic illnesses. So mine was uncommon because it started when I was a teenager, but it's mostly common in older adults. So you have heart disease, arthritis, lupus, Parkinson's, HIV and AIDS, although that, you know, life expectancy is really growing in that group. Crohn's disease, multiple sclerosis, epilepsy, kidney disease, chronic pain, asthma, cancer. And so if you think about this, and one thing that's really interesting right now is that these people then are much more susceptible to other illnesses, right? They're much more susceptible to COVID. In fact, this list of examples are the people who were the first to receive like the COVID vaccinations. And so it's important to understand that chronic illness impacts your overall health, not just the health of the particular part that's hurting. All right, so model of chronic illness is different from acute conditions. So what are acute conditions?
What was the question? I'm sorry.
What are acute conditions? So we're looking at two different types of conditions, chronic and acute.
COVID would be acute, right?
Yeah, acute would be something that
Like
leaves.
temporary.
Right, a sunburn, a cold, the flu, a temporary, right? So, so that model, and one thing I will emphasize, and if for those who were saying that they didn't do well on the last exam, I'm not sure if you guys are psych students or not, but health psychology looks a little bit different than other psychological disciplines because it's medical. There are it really is based on models, right? We've talked about some of them, the immunosuppression model from the last exam, the health belief model, right? Illnesses and health are in models. So when you're studying and looking through this, one of the best things, and this will be true for all of your tests, will be to make sure you understand the models. So right here, the model of chronic illness is different from acute conditions. And then beliefs about chronic illness, the cause of the disease, self-blame, controllability of the disease, right? All of those feed into the belief about that the person with chronic illness has about the illness. So chronic illness, unlike acute illness, and difference in that model is that chronic illness is more than physical symptoms. Cognitive, emotional, social, and behavioral consequences of illness can be profound. The psychological adjustment to the illness may start as a crisis, marked by physical, social, and psychological disequilibrium. Can you think of an example of why, of adjusting psychologically to illness could be like a crisis?
Like for the example that she gave when it came to the I forget the name of it, but when you have the pain and say, but you don't have any tissue damage.
Right.
So just getting to kind of understand how it's possible that you have that, then also trying to get everyone around you to understand that it exists and getting therapy.
Yeah, fibromyalgia, I think, is the one.
That fibromyalgia is one of them, yes. Where it's just no known trigger or reason as to why it's happening, but you're still having the it's still the perception of the pain. So just trying to wrap your head around that, I guess, would be psychologically a crisis. And then having to everybody else wrap their head around that would be.
I can tell you when I was diagnosed with arthritis, that one of the treatment options, basically, because it can't be fixed, it causes like this, it's been 15 years or something. I'm older than you guys. And, you know, I know that it's going to cause progressively worse disability through my life. I mean, there's no getting around it. That's what this is. And so one of the treatments is just therapy, accepting it, right? That's a hard pill to swallow in chronic illness. Like, this is so bad, we can't fix it, but we can have you learn how to live with it. And so that, so there's that correlate, that comorbidity, right? Chronic illness has a comorbidity with depression, anxiety. So they interplay on one another. So here, I'm going to move through fast. I don't want to, we could talk about this one forever, but so there's denial, anxiety, again, as a comorbidity. You could see someone really having anxiety that interferes with their life. Depression, long-term sad mood. So here is, this is something you should know, all right? Pencils out. I don't know if this will be on the test, but I can tell you that theories and models are good things to be aware of. So we have the theory of cognitive adaptation, which has three main themes: search for the meaning in the experience, attempt to regain mastery over the event and over one's life more generally, effort to restore self-esteem through self-enhancing evaluations. Can anyone make up or think of an example of that? Of this process of cognitive adaptation?
Therapy.
Mm-hmm. Well, search for meaning in the experience, right?
Right. So searching for meaning in the experience.
Put the water on, please, mommy.
So you're looking for an example of the,
Well, like
the
think
theory
of, I'm trying to
itself,
think,
right?
right?
Or
Like,
just
so
the
let's
three main
say,
things?
so someone with a chronic illness, right? They may adapt better if they can come up with meaning for why it's happening.
Oh, so
Right?
maybe someone who has cancer or coronary disease or cardiovascular disease, finding out that it runs in their family or that it's hereditary.
Mhm.
Could be something when it comes to meaning.
Yeah, absolutely. Attempt to regain mastery over the event. Maybe for people with diabetes, right? Or diabetes 2, diabetes 1 is different, but type 2 diabetes, which is chronic, regain mastery over it, right? I'm eating better. I'm exercising. Sorry, I have to close the door. The wind's blowing it. I'm eating better. I'm exercising. I am regaining mastery over that. And then to restore self-esteem. So that's again a therapy thing. So let's go. I'm going to go through. All right.
And for the regaining mastery, would that be like a secondary, I forget the name of it, but there's a primary and secondary
Appraisal.
appraisal, exactly. Secondary
Right,
appraisal.
absolutely.
Yeah.
So here again, I'll just use my own experience. Is that I was really worried that I would have to have people open things for me and do anything that required fine motor ability for forever, which sucks. I'm way too young to have that happen. So finding special tools that allow me to stay independent, right? That's mastery. I'm just remastering things that I shouldn't be able to do, but I'm finding ways around it so that those don't become things that I can't do. And I think that that's an important part of that. The other one, and here we go, is social support. And then having a care team, right? This is especially important for people with really critical chronic illnesses. All right, psych interventions. Post-traumatic growth is good to know. I don't know if that's going to be on there. Let's see. Okay, so any questions on that one before I move on to the next set of notes? No, we're good.
Really quick, I'm sorry. So I can note it. What chapter was that again?
Let's see.
I think it's chapter 11.
Because I have okay. I'm on the 10th edition. So okay, chapter 11.
Yeah.
Thank you.
Okay, you guys. Let's see.
I think it was chapter 7.
No, chapter 11 is quality of life and chronic illness management.
Oh,
So that's
I'm
what we
thinking
just
chapter
went through.
in the PowerPoint because it says like chapter 7.
Okay, thank you.
So that's chapter 11 and pages 180 through 181.
Do you mind going over the models really quick?
Let's see.
Which models is for this chapter?
For that one, let's see. I would know health-related quality of life.
Okay.
I would definitely know about the psychological impacts of chronic illness. And this theory of cognitive adaptation. Again, I can't guarantee that those are going to be on there, but if I'm studying for it, I'm looking for things like that. So we went through coping, right? Social support. I would look at the kinds of support for chronic illness. All right, so next chapter was cancer. And we are going to go through. So it's important to know about cancer that, we lump all cancers together. Cancer is just an abnormal growth of cells. And that's how they're related, right? There are many different kinds of cancers. So it's a general term for the abnormal growth of cells. So I would probably want to know what the multiple hit theory is, that cancer comes from multiple places. You have genetics, environment, and lifestyle. I would want to know something about how cancer cells grow. So this is important as well, the types of tumors, right? And like I was saying, cancer is just the word for an abnormal grouping of shells. That's a beach, of cells. And so these are the different types of those groupings. So you have carcinomas, which develop in epithelial tissues around internal organs. So epithelial or skin tissues. Sarcomas develop in the connective tissues. Leukemia develops in the white blood cells. Lymphomas develop in the lymph tissues. And other types, very rare cancers that develop in other part of the body, like gliomas, brain cancer. And then there are different ways that those tumors are classified. They have different, they're either differentiated or undifferentiated, which measures the amount of mutation. They have different grades, and ultimately those lead into the cancer stage, right? Where if the cancer has become metastatic, then that means that the cancer has moved outside of the initial growth of cells. Okay, so cancer epidemiology, lifetime risk of any cancer. Men, you got a 50% chance, women, 33%. So here we go, therapies, surgery, chemotherapy, radiation. There's other hormone immunotherapy and stem cell transplants. For people, those of you psychologists who might be interested in the convergence of psychology and oncology, there is psycho-oncology, a subspecialty dealing with the psychological responses of patients to cancer and how their family reacts, and then also of the factors that contribute to cancer morbidity and mortality. Here are the steps for the psycho-oncological steps for patient care: prevention, pre-diagnosis, asymptomatic screening, diagnosis, treatment, post-treatment and survivorship, recurrence, palliation, and grief. All right, I'm gonna have one what are you guys thinking of? What risk factors? I have them up here, but what are the cancer risk factors that you guys know just right off the top of your head?
Alcohol.
Unhealthy eating.
Mm-hmm.
Foods,
Yep.
smoking, secondhand smoking.
Then there's things that you can't even help, like your age, family history. Like we were talking about the multiple hit theory, it comes from a lot of different places. So there are many screening tests available, right? Women, when you hit 40, you need to start having a mammogram annually. Men start having colonoscopies as they get older. And then, so adjusting to cancer, psychological interventions. Let's see. All right. Anyone else want to run through anything on the cancer chapter? We have about a half hour more, so I want to try to get to everything.
No, thank you.
All right, thank you. On to arthritis. All right. So we covered a lot of this when we were talking about chronic illness just a little while ago. So the term arthritis encompasses more than 100 diseases and conditions affecting joints. Common types, osteoarthritis and rheumatoid arthritis and gout. Gout's a weird one. It used to be called the rich man's disease because the ways of getting it, it's a buildup of like uric acid that you get from eating like fatty cuts of meat. Uncommon are words I can't pronounce: juvenile arthritis, psoriatic arthritis, which is what I have, lupus, and scleroderma. Arthritis risk factors: age, gender, genetics, obesity, joint injuries, infection, occupation. And then again, we went in and what did we discover was the difference between acute and chronic?
Short term, temporary, and long term.
Perfect.
There's terminal.
And so there are others too. So acute pain then has a specific trigger, temporary or brief, disappears with healing, adaptive learning, danger, pain, and adaptive. Yeah, you learn too, right? So like I broke my leg playing soccer and that was an acute pain. And I never did that again because I had to adapt to, those kind of things happening. Chronic pain, origins may not be known, general categories. These are something that I would probably want to have some idea of. Benign, unresponsive, recurrent, intermittent, progressive, worsening, not adaptive. Avoiding activities does not improve underlying pathology. Arthritis is a great example of this. It hurts to walk, so you don't want to walk, but the less you walk, the less mobility you have. So a third of adults report chronic pain, which costs 100 billion annually. You guys will need to know about gate control theory. So I'm going to have one of you, if you can, explain it to me. Friends, Romans, countrymen. Lend me your ears.
I'm guessing this is what we were talking about when it comes to the perception of pain.
Right.
So that it's basically whatever tissue might have been damaged or whatever might be broken, then that area sends it's a signal to the brain, and I guess specifically the emotional state. Okay, so it sends the signal that regulates the pain, or it sends a signal that it's actually pain, and then it then regulates. I guess the dorsal horn is to actually regulate it.
Right. Yeah, that's a good, it's an interesting, if you guys want to get it, well, let's do I'm a democratic person. We have 9 of you, 9 of us. I have a short video on gate control theory that we could watch if you guys wanted to get into it more. Or it's about 5 minutes long, or I could just briefly describe it and we can move on. It's your guys' time. We have a half hour. So I want to use it as you guys think, what you guys think is best.
Can you actually send the link within the chat and we'll just watch it on our own time so then you can briefly discuss it?
Wow, that is the smartest solution. Yes, genius. Yeah, absolutely. Hold on, let me do that. That
Thank you
is
very much.
brilliant. All right, so let me. Okay. So I'll briefly describe it as well. It's one of the most interesting, to me, theories, because I study how trauma impacts your physical health, right? So this is where they're talking about gate control, that there are psychological factors that regulate your pain signaling, right? That those open and close the gate. It's so that you have more, the idea is that an individual has a lot more control over their pain signaling, or can, right? And that when you, as a clinician, you see people, with the same injuries, one experiencing, the most pain they've ever experiencing and the other one not, that person who's experiencing that higher pain is feeling that pain, but it also could be due to, there's the dorsal horn, the input it receives takes into account the, psychological and emotional state of someone. So, all right, I broke my leg. It did not hurt right away. And I had like a compound fracture. It didn't hurt for an hour or two. So my psychological state, my emotions, I was so upset, so much adrenaline that obviously should have hurt. My leg was broken. It was a compound fracture. It was horrific. But my dorsal fin was regulating it differently. So does that kind of make sense? Yes.
Yes.
It does, thank you.
Thank you. I just need reassurance, guys. Talking into the dark.
Yes. It does. Sorry.
So the next is, and this is super interesting because it all goes back. And I would then, if I were you, write this down to know the neuromatrix theory. Right, that sensation of pain in an amputated or missing limb, phantom pains occur. So remember the video she showed?
Yes.
Right, that it wasn't a gate control theory about the pain, right? Because there was no pain to gate control. But they were able to mimic those movements, right, with the mirror that they were using. So,
And that was the neuromatrix theory, right?
right, is that it proposes basically that pain is a multidimensional experience, and that it's the nerve impulses can be retrained. If that makes sense. I could get you a better definition if you like an actual one, if that would make you feel better.
Yes, sure.
Yeah, it might
But
make me feel better too. All right, hold on, give me a second because I don't want you guys to fail. And they're like, I don't know, she described it wrong. All right. All right, here, I'll put it in the chat. this is the definition. But I'll also read it out loud. So the neuromatrix theory of pain states the perception of painful stimuli does not result from the brain's passive registration of tissue trauma, right? So that is not the brain remembering how much it hurt, but from its active generation of subjective experiences through a network of neurons known as the neuromatrix. So your brain has had the subjective experience of having a leg, right? And it can't understand that the leg is gone. And so that's the definition. There's a video as well that she has in here if you want to. I think that's a video of them doing the training with Mir. Okay. So what have we learned about pain measurement today? It's inconsistent, right? All 9 of us in here,
Subjective.
huh?
Sorry. Oh, I said subjective.
Yeah, for sure. It's subjective. And if you break your wrist on the same day your mom dies, that's gonna hurt more, right? Than if you break your wrist on a different day. That pain is also contextual. And I think that that's a very important thing to realize, that outside contexts impact us tremendously, right? Poverty would be, I bet you break your leg and you know that you're going home to a bedroom you're sharing with 4 people and the electricity might not be on and there might not be food, is different than the same exact injury or pain happening to someone who is able to go and be somewhere where they feel safe. And know that they have the ability to take care of it. And that is what context is, that pain, there's a context for it. And that can be, it's multifactorial, but that can be the neighborhood you're in, it can be genetics, but there are just a wide variety of things that contribute. Chronic pain patients' predispositions to certain bodily reactions, tense jaw, altered posture, highly sensitive to noxious stimulation, impairment of pain regulatory system, tendency towards psychological distress, poor emotion regulation, again, the comorbid depression, anxiety, substance abuse, right? When one of the treatment options for the pain that you're constantly in is not a medicine to make that pain go away, but CBT to make you learn how to deal with pain. A lot of people start using substances. And so let's see. We will touch on this and then moving on. So pain management versus pain care. Pain management, medical therapy, non-steroidal anti-inflammatory drugs, opioid analgesics, highly addictive. Speaking of which, have any of you watched Dope Sick on Hulu? No.
No, but I will be noting that.
Immediately. It is so good. Anyhow, speaking of opioids and pain, it really just feeds into a lot of what we're talking about here. So psychological interventions, right? Cognitive behavioral therapy, acceptance and commitment, learning how to do relaxation, right? So that's the treatment for chronic pain. So, which is kind of sucks for people in chronic pain. So any questions about chronic pain and arthritis before we move to cardiovascular? No. All right. All right. Any specific questions about coronary heart disease and diabetes before we start? No. All right. All right. So defining coronary heart disease. This is the #1 killer now because we're living so long and we're beating all the cancer. you know, people beat cancer. You have to die somehow. And coronary heart disease is starting to become how many people go out. So impairment of heart function due to inadequate blood flow to the heart caused by obstructive changes in coronary circulation. There's atherosclerosis, linings of arteries thicken with accumulated cholesterol and other fats. Blood circulation in the heart becomes reduced, right? This is stuff, I go to the doctor now and they look at cholesterol to see, and it's important that you guys do too. So defining coronary heart disease, ischemia. So there's 3 different types, and I would know this for the exam and be able to kind of describe what these are. Ischemia, arteries that supply the heart are narrowed, restricting blood flow to the heart. Angina pectoris, chest pain due to this usually passes within a few minutes without much damage. So a myocardial infarction, that's a complete obstruction of coronary artery and deficiency in blood supply. Portion of the muscle tissue of the heart begins to die. Stroke is an interruption of blood flow to the brain. Neurons in the region begin to die. So let's do a brief overview of the human heart. It's a muscle. It weighs one. Oh yeah, go ahead.
I'm sorry, really quick. For the myocardial, can you scroll up really quick?
Yeah.
For the myocardial infarction, isn't that a heart attack?
Mm-hmm.
Okay.
So yeah, so this is perfect. So ischemia, you know, when they go and they're like, oh, he had a mild heart attack or an ischemic event, right? Those are like the kind of precursors. Myocardial infarction that's a heart attack. And that comes from this, and that's where, and then a portion of the muscle tissue of the heart begins to die.
Okay, thank you.
You're welcome.
Just making sure.
So human heart, it's the size of a fist. Go ahead. Oh, never mind. Located behind and slightly left of the breastbone, pumps about 5 quarts of blood every minute. Coronary heart disease, #1 cause of death globally. See, taken bets. I'm sorry that I joke about that. 28.1 million persons with confirmed diagnosis. 610,000 people in the US die from heart disease every year. That's less than COVID though. 28.1% of deaths in California are due to heart disease. And it costs approximately $110 billion annually. So again, what have we noticed with all of these diseases, guys? Is it caused by just what the person does?
No.
No, it is multifaceted, right?
Yeah.
There are environments, genetics, and like I said, contexts for all of these. We've looked at cancer, we've looked at chronic illness, we've looked at arthritis, we're looking at coronary heart disease. What we can say is that they are multifactorial, right? Context matters. How you treat your body matters. Your habits matter. How your parents treated you matters, right? There's so many different parts of it. So here we're looking at the same thing, metabolic. So this is the stuff in you that you can control. Behavioral, you know, although sometimes people have high blood pressure in their families, right? Behavioral, tobacco use, not doing any exercise, diet high in salt, fat, and calories, and drinking. Others are demographic, age, gender, socioeconomic status, right? Being poor is hard and it impacts people drastically. Genetics, psychosocial factors, right? Your personality, we talked about that, type A personalities, depression. And then here we go. We've got 15 minutes. Do you want me to get into the type A and B personality patterns or move through it?
I think I'm pretty versed on type A and type B. I'm not sure about everybody else.
Yeah, I'm fine also.
All right, I figured. And thanks for being the type A's who told me. so we can move forward. I appreciate that. Sorry. It's only Monday, guys. Let's go through. So hostility is a long-lasting negative attitude, right? You can see why hostile people get more coronary heart disease. Anger is a negative again. Makes sense why the coronary heart disease and anger. Gender, women predicted at younger ages relative to men. So, and that it looks like is tied into menopausal issues, so that the cholesterol levels, you have more good cholesterol before menopause. And then once you go through menopause and your body is not made for making babies anymore, that makes sense. So women have a higher chance of dying from their first heart attack, and symptoms are different in heart attacks in men and women. So I think we all know some, cardiac rehabilitation, there's medication, improved diet, physical activity, stress management, social support, reducing symptoms of depression. All these post-heart attack, heart disease treatments are also good to prevent them. So defining diabetes, someone tell me the difference between type 1 and type 2.
I believe for type 1, it's more, I believe you have insulin, and I think it's less able to control. I believe it's also a more early onset than it is for type 2. And then also, I think type 2 is more common.
Right. So yeah, you've got a lot of the good points. So type 1 is something that you're born with, right? Your pancreas. Mommy, my daughter's hiding behind me too.
Oh, sorry.
No, so type 1 is you're born with it. Your pancreas doesn't create enough insulin. People died from this, didn't make it out of childhood before insulin injections changed. So type 1 is not the person's fault. Type 2, which is 90%, is the one that your genetics and lifestyle cause, right? So those are the ones where the diet, exercise, medication, injections, when they tell people that they're becoming pre-diabetic, they're saying they're becoming pre-diabetic type 2 diabetics. So defining, I would know hypoglycemia and hyperglycemia. Health complications, sorry, I'm gonna rush through this. Epidemiology. So 7th leading cause of death. And again, we've got modifiable things and unmodifiable, like with all of the diseases we're seeing. Psychological interventions that can be done is health behavior changes, medication compliance. Although if the health behavior changes occur, a lot of times you don't need the same amounts of the medication. Social support. And all right. So how do you guys feel about diathesis stress model? Seeing this on here, could you guys just really quickly apply the diathesis stress model to coronary heart disease or diabetes?
Next question.
I believe it's for if you're like you have a predisposition for the disease versus I'm sorry.
No, you're good.
Maybe so sorry. Okay, she's not going.
It's okay, you're good. No, but you had, yes. So let's say for diabetes type 2, the diathesis stress model would, here, I'm gonna stop sharing And instead, I'm going to share my face. Hi, all. I'm going to draw you a little picture. All right. And you guys are going to be amazed at my art skills. All right. This, can you see that? Is a cup. At the top is diabetes. If you fill up the cup with things, you get diabetes, right? So let's say you had a genetic history for diabetes, right? So that's going to fill up part of the cup. Let's say that you're a smoker.
Your lifestyle.
Right. That's going to fill up part of the cup, right? So we're getting there. And then let's say you add obesity right there. You're getting closer, right? And so the diathesis stress model is saying that we have these predispositions, these vulnerabilities, right? Once you cross this, you cross a threshold of vulnerability. And you get the disease, you know, so the genetics aren't going to do it to you alone. The smoking, the obesity, right? Those things wouldn't fill this cup on their own, but they will fill it all together. And then that person will have diabetes. So let me see what the last, oh, that was actually it. We have gone through all of those slides.
Yeah, diabetes was the last thing that we discussed.
Okay. Are there questions or anything that you guys have? Because we've got 8 more minutes before I have to go out into the horrible rain. Were there, oh, go ahead.
No, I was just gonna say, I think it's pretty, you did well with going over what you did, and I think we'll just have to go over the slides and then just get more in depth with it for them. At least we have the guide as to what we need to know.
Right, and I will give you guys all, so I had Dr. Merz for advanced stats. And what I would do is, you know how we had those notes there? I would print them out and I would add to them, because if she's still doing it the way she did it in mine, she has the exact same slides that she shows you, but her slides have a little bit more on them. And those, if you fill in what those additional notes are that make the notes that you can print out and differentiate those from the slides that she's showing when she's presenting, a lot of that is the stuff that is on the exams. Does that make sense?
Yeah.
Yes, thank
She
you.
has the
print,
notes, and
yeah, so
then
print out the notes. I put them for both classes I had with her. I printed them out. I put them in a 3-ring binder. I separated them by unit, right? And then when in class, I would just write out the notes, the additional parts.
Right.
And that was, I mean, I got A's in both of them. So that is my, and then again, I'm here doing this every Monday, not to this extent, but if you have any questions, if you need help, I'm the one grading your essays. So if you need any help with the essays, just come find me. I'm here. I get paid for it, sitting here at my desk for an hour. So you might as well use it.
nice. That's good to know. Thank you so much.
You're welcome. All right, I'm going to end this, but I will be sending out the recording.
Stop.
Thank you.